Question 1. A patient with chronic gastrointestinal bleeding presents with pallor and fatigue. Which of the following lab findings would be most indicative of iron deficiency anemia due to chronic blood loss? A. Low respiratory count with elevated ferritin levels. B. Low serum iron and low ferritin levels with high total iron binding capacity, TIBC. C. Elevated mean corpuscular volume, MCV, and low hemoglobin. D. Normal serum iron and low transferrin saturation. Answer: B. Low serum iron and low ferritin levels with high total iron binding capacity, TIBC. Rationale: chronic blood loss results in iron deficiency anemia, which is characterized by low serum iron, low ferritin, and elevated TIBC. This combination reflects a depletion of iron stores and a compensatory increase in transferrin to bind available iron. Elevated MCV and low hemoglobin suggest macrocytic anemia, not iron deficiency. Normal iron levels with low transferrin saturation would suggest anemia of chronic disease, rather than iron deficiency. Question 2. A 45-year-old patient with long-standing rheumatoid arthritis presents with fatigue, low hemoglobin, and a history of chronic inflammation. Which of the following would be the most appropriate next step in diagnosing the cause of anemia? A. Bone marrow biopsy. B. Iron studies, serum iron, ferritin, transferrin saturation. C. High-dose vitamin B12 supplementation. D. Erythropoietin EPO level assessment. Answer: B. Iron studies, serum iron, ferritin, transferrin saturation. Rationale: anemia of chronic disease, ACD, is common in patients with rheumatoid arthritis due to chronic inflammation affecting iron metabolism. Iron studies are key in differentiating ACD from iron deficiency anemia. Bone marrow biopsy is typically not the first diagnostic step for ACD, and vitamin B12 supplementation would not address anemia of chronic disease. EPO levels are more useful in diagnosing anemia secondary to kidney disease. Question 3. A patient with sickle cell disease presents with severe pain in the chest, abdomen, and joints. What would be the most appropriate initial intervention for managing this acute vaso-occlusive crisis? A. Administer erythropoiesis-stimulating agents, ESAs. B. Administer intravenous fluids and oxygen. C. Start blood transfusions immediately. D. Administer iron supplementation to increase hemoglobin levels. Answer: B. Administer intravenous fluids and oxygen. Rationale: the primary management of a vaso-occlusive crisis in sickle cell disease includes intravenous fluids to maintain hydration and oxygen therapy to improve oxygen delivery to tissues. Blood transfusions and iron supplementation may be needed in certain situations, but they are not the initial intervention for an acute pain crisis. Erythropoiesis-stimulating agents are not used in sickle cell disease for pain management. Question 4. A 60-year-old male patient with a history of chronic kidney disease and anemia presents with fatigue, shortness of breath, and pallor. His serum creatinine is elevated, and his hemoglobin is low. Which treatment should be considered to address his anemia? A. High-dose vitamin B12 injections. B. Erythropoiesis-stimulating agents, ESAs, and iron supplementation. C. Monthly blood transfusions. D. Oral iron supplementation alone. Answer: B. Erythropoiesis-stimulating agents, ESAs, and iron supplementation. Rationale: anemia in chronic kidney disease is typically treated with erythropoiesis-stimulating agents, ESAs, to stimulate red blood cell production. Iron supplementation is often needed to ensure adequate iron for erythropoiesis. High-dose vitamin B12 and blood transfusions are not standard treatments for anemia in chronic kidney disease unless other causes are identified. Oral iron supplementation may not be sufficient if the anemia is more severe. Question 5. A patient presents with severe anemia, fatigue, and pallor. Laboratory results show a high mean corpuscular volume, MCV, low vitamin B12, and elevated homocysteine levels. Which of the following would most likely be the cause of this patient's anemia? A. Folic acid deficiency. B. Iron deficiency anemia. C. Vitamin B12 deficiency, pernicious anemia. D. Anemia of chronic disease. Answer: C. Vitamin B12 deficiency, pernicious anemia. Rationale: low vitamin B12 levels and elevated homocysteine levels, along with a high MCV, are indicative of pernicious anemia, a form of megaloblastic anemia. Folic acid deficiency can cause similar findings, but does not typically elevate homocysteine levels in the same way as B12 deficiency. Iron deficiency anemia typically presents with microcytic anemia, low MCV, not macrocytic. Anemia of chronic disease would not show elevated homocysteine levels or a high MCV. Question 6. A 50-year-old female with a history of menorrhagia presents with pallor, weakness, and dizziness. Her iron studies reveal low serum iron, low ferritin, and high total iron binding capacity, TIBC. Which of the following treatments would be most appropriate for her condition? A. Oral iron supplementation. B. Vitamin B12 injections. C. Folic acid supplementation. D. Blood transfusions. Answer: A. Oral iron supplementation. Rationale: the patient's symptoms and laboratory findings are consistent with iron deficiency anemia, most likely caused by menorrhagia. Oral iron supplementation is the first-line treatment for iron deficiency anemia. Vitamin B12 and folic acid supplementation are not appropriate unless deficiencies are identified. Blood transfusions are typically reserved for severe cases of anemia. Question 7. In a patient with chronic anemia secondary to chronic kidney disease, which of the following lab values is most likely to be low? A. Hemoglobin. B. Serum ferritin. C. Erythropoietin (EPO) levels. D. Respiratory count. Answer: C. Erythropoietin (EPO) levels. Rationale: in chronic kidney disease, erythropoietin production is impaired, leading to decreased red blood cell production and anemia. Hemoglobin, serum ferritin, and respiratory count can be low in anemia, but low EPO levels are the most consistent finding in this condition. Question 8. A patient with a history of bone marrow suppression and severe anemia is being considered for a blood transfusion. Which of the following would be the most important consideration before administering the transfusion? A. The patient's blood type. B. The patient's risk of hyperkalemia. C. The patient's baseline hemoglobin level. D. The patient's history of transfusion reactions. Answer: D. The patient's history of transfusion reactions. Rationale: before administering a blood transfusion, it is critical to assess the patient's history of transfusion reactions to prevent potential allergic or hemolytic reactions. Blood type is important, but already established in blood banks. Hyperkalemia is not typically a concern unless there is significant blood transfusion volume or old blood. Baseline hemoglobin is relevant, but not as critical as transfusion history. Question 9. A 30-year-old pregnant woman with anemia is found to have a hemoglobin level of 8 gram per deciliter. She also has a low respiratory count and elevated MCV. What is the most likely cause of her anemia? A. Iron deficiency anemia. B. Vitamin B12 deficiency. C. Folate deficiency. D. Anemia of chronic disease. Answer: B. Vitamin B12 deficiency. Rationale: the elevated MCV and low respiratory count in the presence of anemia suggest a megaloblastic anemia, most commonly caused by vitamin B12 deficiency. Folate deficiency can present similarly, but vitamin B12 deficiency is more common in pregnant women. Iron deficiency anemia typically presents with microcytic anemia, low MCV, and anemia of chronic disease typically does not present with elevated MCV. Question 10. A patient with sickle cell disease is presenting for routine care. The nurse is educating the patient about managing triggers for vaso-occlusive crises. Which of the following should the nurse prioritize in the teaching plan? A. Avoiding high-intensity exercise. B. Staying hydrated and avoiding extreme temperatures. C. Avoiding iron-rich foods. D. Resting in a supine position to improve blood flow. Answer: B. Staying hydrated and avoiding extreme temperatures. Rationale: vaso-occlusive crises in sickle cell disease are often triggered by dehydration and extreme temperatures. Staying hydrated and avoiding extreme cold or hot environments is crucial in preventing these crises. High-intensity exercise can exacerbate the condition, but hydration and temperature control are more directly related to crisis prevention. Iron-rich foods are not typically a concern unless iron overload is present. Resting in a supine position is not beneficial for preventing crises. Question 11. A patient with anemia presents with jaundice, dark urine, and a history of recent infections. What is the most likely cause of these symptoms? A. Hemolytic anemia due to autoimmune destruction of red blood cells. B. Chronic kidney disease-induced anemia. C. Iron deficiency anemia leading to iron overload. D. Anemia of chronic disease due to inflammation. Answer: A. Hemolytic anemia due to autoimmune destruction of red blood cells. Rationale: hemolytic anemia due to autoimmune destruction of red blood cells is characterized by jaundice, from bilirubin breakdown, and dark urine, from hemoglobinuria. Recent infections can trigger an autoimmune response. Chronic kidney disease-induced anemia and anemia of chronic disease typically do not cause jaundice or dark urine. Iron deficiency anemia may cause pallor and fatigue, but not jaundice or dark urine. Question 12. A patient presents with fatigue, pallor, and a history of pernicious anemia. What lab result would confirm that the patient's anemia is due to vitamin B12 deficiency? A. Low ferritin and high total iron binding capacity, TIBC. B. Low vitamin B12 levels and elevated methylmalonic acid, MMA, levels. C. Low hemoglobin and elevated respiratory count. D. High mean corpuscular volume, MCV, and low vitamin D levels. Answer: B. Low vitamin B12 levels and elevated methylmalonic acid, MMA levels. Rationale: vitamin B12 deficiency, particularly in pernicious anemia, is confirmed by low vitamin B12 levels and elevated methylmalonic acid, MMA, which reflects impaired B12 dependent metabolic processes. Low ferritin and high TIBC are indicative of iron deficiency anemia. An elevated MCV with low hemoglobin suggests megaloblastic anemia, but MMA levels are more specific to vitamin B12 deficiency. Elevated respiratory count would not be expected in B12 deficiency unless there is concurrent acute blood loss. Question 13. A 40-year-old female with a history of chronic menorrhagia presents with fatigue and pale mucous membranes. Which of the following findings would be most suggestive of iron deficiency anemia? A. Low hemoglobin and elevated respiratory count. B. Low ferritin and high total iron binding capacity, TIBC. C. High mean corpuscular volume, MCV, and low red blood cell count. D. High serum iron and low transferrin saturation. Answer: B. Low ferritin and high total iron binding capacity, TIBC. Rationale: in iron deficiency anemia, ferritin is low due to depleted iron stores, and TIBC is elevated as the body increases transferrin to transport iron. Respiratory count is typically low in iron deficiency anemia, not elevated. High MCV and low red blood cell count suggest megaloblastic anemia, not iron deficiency. High serum iron and low transferrin saturation indicate anemia of chronic disease, not iron deficiency. Question 14. A patient with a history of multiple transfusions presents with fatigue and joint pain. The most recent hemoglobin level is 7.5 gram per deciliter. What is the most likely cause of this patient's anemia? A. Hemolytic anemia due to blood transfusion reaction. B. Anemia due to iron overload, secondary to transfusions. C. Folate deficiency from poor nutrition. D. Bone marrow suppression due to chronic disease. Answer: B. Anemia due to iron overload, secondary to transfusions. Rationale: multiple blood transfusions can lead to iron overload, which causes damage to organs like the liver and heart, resulting in anemia. This condition is common in patients with a history of frequent transfusions, such as those with thalassemia or sickle cell disease. Hemolytic anemia due to transfusion reactions typically presents with more acute symptoms, such as fever and chills. Folate deficiency would cause macrocytic anemia, but not iron overload. Bone marrow suppression is more likely to cause pancytopenia. Question 15. A 60-year-old patient with a history of chronic kidney disease presents with pallor, fatigue, and shortness of breath. Laboratory results show low hemoglobin and a low respiratory count. What is the most appropriate treatment for this patient? A. Vitamin B12 supplementation. B. Erythropoiesis-stimulating agents, ESAs, and iron supplementation. C. Blood transfusions. D. Folic acid supplementation. Answer: B. Erythropoiesis-stimulating agents, ESAs, and iron supplementation. Rationale: anemia in chronic kidney disease is typically treated with erythropoiesis-stimulating agents, ESAs, which help stimulate red blood cell production. Iron supplementation is also necessary to support this process. Vitamin B12 and folic acid supplementation are not typically used for anemia in chronic kidney disease unless deficiencies are identified. Blood transfusions may be used in severe cases, but are not the first-line treatment. Question 16. A patient with iron deficiency anemia is being discharged with oral iron supplementation. Which of the following should the nurse include in the teaching plan? A. Take the iron with milk to reduce gastrointestinal upset. B. Take the iron with vitamin C to increase absorption. C. Take the iron in the evening to reduce nausea. D. Take the iron with antacids to reduce stomach acidity. Answer B. Take the iron with vitamin C to increase absorption. Rationale: vitamin C enhances the absorption of iron, making it more effective when taken together. Milk, antacids, and calcium can interfere with iron absorption, so they should not be taken together. Taking iron in the evening may help with nausea, but it is more important to focus on maximizing absorption, which is achieved with vitamin C. Question 17. A 25-year-old female with sickle cell disease presents with severe leg pain, fever, and a low-grade temperature. What is the most likely cause of these symptoms? A. Sickle cell crisis with infection. B. Acute hemolytic anemia due to autoimmune destruction of red blood cells. C. Deep vein thrombosis, DVT, leading to leg pain. D. Gout exacerbation due to hyperuricemia. Answer: A. Sickle cell crisis with infection. Rationale: in sickle cell disease, a vaso-occlusive crisis often presents with severe pain, fever, and low-grade temperature due to the occlusion of small blood vessels by sickled red blood cells. Infection can trigger or worsen a sickle cell crisis. Acute hemolytic anemia, DVT, and gout exacerbation are less likely to present with the combination of fever, pain, and a temperature in this context. Question 18. A patient with anemia of chronic disease, ACD, has low serum iron and normal or elevated ferritin levels. Which of the following is the most appropriate treatment for this condition? A. Oral iron supplementation. B. Erythropoiesis-stimulating agents, ESAs, and iron supplementation. C. Treat the underlying chronic disease. D. Intravenous iron therapy. Answer: C. Treat the underlying chronic disease. Rationale: anemia of chronic disease is a secondary anemia caused by chronic inflammation or infection. The primary treatment is to manage the underlying condition, for example, rheumatoid arthritis, chronic kidney disease. Oral iron supplementation may not be effective in ACD due to the body's inability to properly use iron in the presence of inflammation. Erythropoiesis-stimulating agents, ESAs, and intravenous iron are not the first-line treatments unless anemia becomes more severe. Question 19. A 40-year-old woman with a history of gastric bypass surgery presents with fatigue and pale skin. Lab results show a low hemoglobin level, low MCV, and low vitamin B12. What is the most likely cause of her anemia? A. Iron deficiency anemia due to malabsorption. B. Vitamin B12 deficiency due to impaired intrinsic factor production. C. Folic acid deficiency due to dietary insufficiency. D. Anemia of chronic disease due to gastrointestinal inflammation. Answer: B. Vitamin B12 deficiency due to impaired intrinsic factor production. Rationale: gastric bypass surgery can lead to vitamin B12 deficiency due to impaired intrinsic factor production and malabsorption of B12. This can result in megaloblastic anemia with low MCV and low vitamin B12 levels. Iron deficiency anemia and folic acid deficiency are also possible after gastric bypass, but the most likely cause given the patient's history and labs is vitamin B12 deficiency. Anemia of chronic disease would not typically present with low B12. Question 20. A 70-year-old male patient with long-standing diabetes and hypertension presents with weakness and pallor. His hemoglobin is 9 gram per deciliter, and his respiratory count is low. Which of the following would be the most appropriate next step in his management? A. Start a blood transfusion. B. Begin oral iron supplementation. C. Assess renal function to evaluate for anemia of chronic disease. D. Administer erythropoiesis-stimulating agents, ESAs, without further testing. Answer: C. Assess renal function to evaluate for anemia of chronic disease. Rationale: given the patient's history of diabetes and hypertension, anemia of chronic disease, ACD, should be suspected, and assessing renal function is crucial because chronic kidney disease can contribute to ACD. Blood transfusions and iron supplementation are not first line for ACD, and erythropoiesis-stimulating agents, ESAs, should only be used if the underlying condition, such as kidney disease, is confirmed. Question 21. A 50-year-old female patient with a history of gastric bypass surgery presents with fatigue and tingling in her hands and feet. Her hemoglobin is 8.5 gram per deciliter, and her vitamin B12 level is significantly low. What is the most likely cause of her anemia? A. Iron deficiency anemia due to malabsorption. B. Vitamin B12 deficiency due to malabsorption. C. Folic acid deficiency due to malabsorption. D. Anemia of chronic disease due to inflammation. Answer: B. Vitamin B12 deficiency due to malabsorption. Rationale: after gastric bypass surgery, malabsorption of vitamin B12 is common due to the reduction in the stomach's ability to produce intrinsic factor. This leads to vitamin B12 deficiency, which causes megaloblastic anemia and neurological symptoms such as tingling. Iron deficiency anemia and folic acid deficiency may also occur but would not explain the neurological symptoms, and anemia of chronic disease typically presents with normal or elevated ferritin levels, not low vitamin B12. Question 22. A 20-year-old female presents with fatigue, pallor, and dizziness. Lab results show a hemoglobin level of 10 gram per deciliter, a mean corpuscular volume, MCV, of 72 FL, and a respiratory count of 1%. Which of the following would be the most likely cause of her anemia? A. Iron deficiency anemia. B. Vitamin B12 deficiency. C. Sickle cell anemia. D. Anemia of chronic disease. Answer: A. Iron deficiency anemia. Rationale: the low MCV, microcytic anemia, and the low hemoglobin level are most consistent with iron deficiency anemia, which typically presents with microcytosis. A respiratory count of 1% suggests a low production of red blood cells. Vitamin B12 deficiency causes macrocytic anemia, not microcytic. Sickle cell anemia would not present with a low MCV and low respiratory count in this context. Anemia of chronic disease typically presents with normal or elevated ferritin and low iron levels. Question 23. A patient with a history of chronic alcohol use presents with weakness and a new-onset sore tongue. A CBC reveals a hemoglobin level of 9 gram per deciliter, high MCV, and low vitamin B12. Which of the following is the most appropriate treatment? A. Oral iron supplementation. B. Vitamin B12 supplementation parenteral. C. Blood transfusion. D. Folic acid supplementation. Answer: B. Vitamin B12 supplementation parenteral. Rationale: chronic alcohol use can lead to vitamin B12 deficiency due to poor diet and alcohol's effects on absorption. The high MCV, macrocytic anemia, and low vitamin B12 confirm the diagnosis of pernicious anemia or B12 deficiency. Parenteral, intramuscular, B12 supplementation is typically required because of malabsorption. Iron supplementation and folic acid would not address the B12 deficiency, and blood transfusions are not the first-line treatment unless the anemia is severe. Question 24. A 60-year-old male patient with a history of hypertension and diabetes presents with symptoms of fatigue, shortness of breath, and dizziness. His hemoglobin level is 7.0 gram per deciliter, and his respiratory count is low. What is the most likely cause of his anemia? A. Acute blood loss. B. Anemia of chronic disease ACD due to chronic kidney disease. C. Iron deficiency anemia. D. Hemolytic anemia. Answer: B. Anemia of chronic disease ACD due to chronic kidney disease. Rationale: anemia of chronic disease ACD is commonly seen in patients with chronic kidney disease, diabetes, and hypertension. It results from decreased erythropoiesis and low iron availability despite adequate stores. The low respiratory count suggests impaired red blood cell production. Acute blood loss typically leads to normocytic anemia with a higher respiratory count. Iron deficiency anemia would present with low ferritin, and hemolytic anemia would present with elevated bilirubin and reticulocytes. Question 25. A 22-year-old female presents with fatigue, pallor, and a history of heavy menstrual periods. Her hemoglobin is 8.5 gram per deciliter, and iron studies show low serum iron, low ferritin, and high TIBC. What is the most likely cause of her anemia? A. Vitamin B12 deficiency. B. Folic acid deficiency. C. Iron deficiency anemia. D. Anemia of chronic disease. Answer: C. Iron deficiency anemia. Rationale: the patient's lab results, low serum iron, low ferritin, and high TIBC, are indicative of iron deficiency anemia, most likely due to heavy menstrual bleeding. Vitamin B12 and folic acid deficiencies typically cause megaloblastic anemia, which presents with a high MCV. Anemia of chronic disease would not show low serum iron and high TIBC. Question 26. A 75-year-old patient with a history of rheumatoid arthritis presents with fatigue and pallor. Lab results reveal a hemoglobin of 9.2 gram per deciliter, low serum iron, elevated ferritin, and normal vitamin B12 levels. What is the most likely cause of his anemia? A. Vitamin B12 deficiency. B. Anemia of chronic disease, ACD, due to rheumatoid arthritis. C. Iron deficiency anemia. D. Folic acid deficiency. Answer: B. Anemia of chronic disease, ACD, due to rheumatoid arthritis. Rationale: anemia of chronic disease, ACD, is often seen in patients with chronic inflammatory conditions like rheumatoid arthritis. The low serum iron, elevated ferritin, and normal vitamin B12 levels are characteristic of ACD. Inflammatory cytokines reduce iron availability and impair erythropoiesis. Vitamin B12 deficiency, iron deficiency anemia, and folic acid deficiency would have different lab profiles. Question 27. A 40-year-old male patient with a history of chronic alcohol use presents with jaundice, dark urine, and abdominal pain. Lab results reveal a hemoglobin of 8.0 gram per deciliter, elevated respiratory count, and high bilirubin. What is the most likely cause of his anemia? A. Hemolytic anemia due to alcohol-induced liver disease. B. Sickle cell anemia with acute pain crisis. C. Iron deficiency anemia with chronic blood loss. D. Anemia of chronic disease from liver failure. Answer: A. Hemolytic anemia due to alcohol-induced liver disease. Rationale: chronic alcohol use can lead to liver disease, which can cause hemolytic anemia due to liver dysfunction and impaired bilirubin metabolism. The elevated respiratory count and high bilirubin levels indicate increased red blood cell destruction. Sickle cell anemia typically presents with severe pain crises, but not jaundice or dark urine unless there is an additional factor like infection. Iron deficiency anemia would not present with elevated respiratory count and bilirubin. Anemia of chronic disease usually has normal respiratory count. Question 28. A patient with a history of frequent blood transfusions presents with fatigue, weight loss, and joint pain. His hemoglobin level is 8.0 gram per deciliter, and his iron studies show high serum ferritin, low transferrin saturation, and elevated transferrin levels. What is the most likely cause of his anemia? A. Iron deficiency anemia. B. Vitamin B12 deficiency. C. Anemia due to iron overload from frequent transfusions. D. Anemia of chronic disease due to inflammation. Answer: C. Anemia due to iron overload from frequent transfusions. Rationale: frequent blood transfusions lead to iron overload, causing a condition known as transfusion-associated iron overload. The high serum ferritin and elevated transferrin levels suggest iron accumulation, while the low transferrin saturation indicates that the iron is not being effectively used. Iron deficiency anemia and vitamin B12 deficiency would present with different lab findings. Anemia of chronic disease does not cause iron overload. Question 29. A 65-year-old patient with a history of chronic heart failure presents with fatigue and shortness of breath. Lab results reveal a hemoglobin of 8.2 gram per deciliter, a normal MCV, and low erythropoietin levels. What is the most likely cause of his anemia? A. Anemia due to chronic disease, ACD, from heart failure. B. Iron deficiency anemia. C. Hemolytic anemia due to heart failure. D. Vitamin B12 deficiency. Answer: A. Anemia due to chronic disease, ACD, from heart failure. Rationale: anemia of chronic disease, ACD, is common in patients with chronic heart failure due to the inflammatory response and impaired erythropoiesis. The low erythropoietin levels suggest impaired red blood cell production, which is characteristic of ACD. Iron deficiency anemia would show low ferritin and hemolytic anemia would present with elevated bilirubin and reticulocytes. Vitamin B12 deficiency is unlikely to cause a low respiratory count and normal MCV. Question 30. A 25-year-old pregnant female presents with pallor and weakness. Her hemoglobin is 9.1 gram per deciliter, and her iron studies reveal low serum iron, low ferritin, and elevated TIBC. Which of the following would be the most appropriate next step in management? A. Administer folic acid supplementation. B. Administer erythropoiesis-stimulating agents, ESAs. C. Begin oral iron supplementation. D. Start a blood transfusion. Answer C. Begin oral iron supplementation. Rationale. The patient's lab results suggest iron deficiency anemia, which is common in pregnant women due to increased iron requirements. The most appropriate next step is to begin oral iron supplementation. Folic acid supplementation is necessary for the prevention of neural tube defects, but does not address iron deficiency. Erythropoiesis-stimulating agents, ESAs, are not typically used in pregnancy unless there is significant anemia. Blood transfusions are reserved for severe anemia, not mild to moderate cases. Question 31. A 45-year-old male patient with chronic alcoholism presents with fatigue, pale skin, and elevated liver enzymes. His hemoglobin is 9.0 gram per deciliter, and his MCV is 105 FL. What is the most likely cause of his anemia? A. Folic acid deficiency due to poor diet. B. Iron deficiency anemia from gastrointestinal bleeding. C. Vitamin B12 deficiency from alcohol-related liver damage. D. Hemolytic anemia due to liver failure. Answer: C. Vitamin B12 deficiency from alcohol-related liver damage. Rationale: chronic alcoholism often causes vitamin B12 deficiency due to poor diet and liver dysfunction, leading to macrocytic anemia, high MCV. Folic acid deficiency can also occur in alcoholics, but the elevated MCV and the patient's history point more toward B12 deficiency. Iron deficiency anemia would present with low MCV and low iron studies, not high MCV. Hemolytic anemia due to liver failure is rare in this context. Question 32. A 60-year-old patient with a history of chronic kidney disease and diabetes mellitus presents with fatigue and pallor. His hemoglobin is 8.5 gram per deciliter, and his serum creatinine is elevated. What would be the most appropriate management for his anemia? A. Erythropoiesis-stimulating agents, ESAs, and iron supplementation. B. High-dose vitamin B12 and folic acid supplementation. C. Blood transfusion and iron supplementation. D. Oral iron supplementation alone. Answer: A. Erythropoiesis-stimulating agents, ESAs, and iron supplementation. Rationale: in chronic kidney disease, the most appropriate treatment for anemia is the use of erythropoiesis-stimulating agents, ESAs, to stimulate red blood cell production, along with iron supplementation to support erythropoiesis. High-dose B12 and folic acid are not indicated unless deficiencies are present. Blood transfusions are used in severe anemia, and oral iron alone is not sufficient in CKD-induced anemia, where the underlying problem is erythropoietin production. Question 33. A 24-year-old female presents with fatigue, a sore tongue, and tingling in her hands and feet. Lab results show a hemoglobin of 7.2 gram per deciliter, MCV of 112 FL, and a low vitamin B12 level. What is the most likely cause of her anemia? A. Vitamin B12 deficiency, pernicious anemia. B. Folate deficiency due to poor dietary intake. C. Iron deficiency anemia with neurological complications. D. Hemolytic anemia due to vitamin B12 deficiency. Answer: A. Vitamin B12 deficiency, pernicious anemia. Rationale: the elevated MCV and low vitamin B12 levels with neurological symptoms such as tingling are classic signs of pernicious anemia, a form of vitamin B12 deficiency. Folate deficiency also causes megaloblastic anemia, but does not present with neurological symptoms. Iron deficiency anemia typically does not cause high MCV, and hemolytic anemia does not present with low vitamin B12 levels. Question 34. A patient with a history of multiple myeloma presents with fatigue and pallor. Lab results show a hemoglobin of 9.0 gram per deciliter, elevated creatinine, and low respiratory count. Which of the following is the most likely cause of his anemia? A. Anemia of chronic disease due to renal failure. B. Iron deficiency anemia due to gastrointestinal bleeding. C. Anemia due to bone marrow suppression from myeloma. D. Vitamin B12 deficiency. Answer C. Anemia due to bone marrow suppression from myeloma. Rationale. Multiple myeloma is a cancer of plasma cells, which can lead to bone marrow suppression, resulting in anemia. The low respiratory count suggests impaired red blood cell production. Anemia of chronic disease from renal failure is also common, but the patient's history of myeloma suggests that bone marrow suppression is the primary cause. Iron deficiency anemia would present with low ferritin, and vitamin B12 deficiency is less likely to cause low respiratory count in this context. Question 35. A patient with a history of sickle cell disease presents with acute chest pain, fever, and dyspnea. His hemoglobin is 6.5 gram per deciliter, and his respiratory count is elevated. What is the most likely cause of these symptoms? A. Pulmonary embolism. B. Acute chest syndrome related to sickle cell disease. C. Acute myocardial infarction. D. Pneumonia caused by infection. Answer: B. Acute chest syndrome related to sickle cell disease. Rationale. Acute chest syndrome is a common and life-threatening complication of sickle cell disease, causing chest pain, fever, and respiratory distress. It results from the sickling of red blood cells in the lungs, leading to pulmonary infarcts and infection. Pulmonary embolism, myocardial infarction, and pneumonia are less likely to present with the combination of symptoms in this sickle cell patient, and the elevated respiratory count further supports an ongoing sickling crisis. Question 36. A 70-year-old male patient with chronic heart failure presents with fatigue, weakness, and pallor. His hemoglobin is 8.0 gram per deciliter, his respiratory count is low, and his iron studies reveal low serum iron, normal ferritin, and elevated TIBC. What is the most likely cause of his anemia? A. Anemia of chronic disease, ACD, due to heart failure. B. Iron deficiency anemia. C. Anemia of chronic disease, ACD, due to renal failure. D. Vitamin B12 deficiency. Answer: A. Anemia of chronic disease, ACD, due to heart failure. Rationale. Anemia of chronic disease, ACD, is common in patients with chronic heart failure due to inflammation and impaired erythropoiesis. The patient's normal ferritin, low serum iron, and elevated TIBC are characteristic of ACD. Iron deficiency anemia would present with low ferritin and high TIBC. Anemia of chronic disease from renal failure would cause elevated creatinine and lower erythropoietin levels. Vitamin B12 deficiency would cause macrocytic anemia, not the normal MCV seen here. Question 37. A 33-year-old female patient with a history of heavy menstrual bleeding presents with fatigue, weakness, and pale mucous membranes. Lab results show low hemoglobin, low serum iron, low ferritin, and high TIBC. What is the most likely diagnosis? A. Vitamin B12 deficiency. B. Iron deficiency anemia. C. Anemia of chronic disease. D. Thalassemia minor. Answer: B. Iron deficiency anemia. Rationale. The patient's history of heavy menstrual bleeding and laboratory findings, low hemoglobin, low serum iron, low ferritin, and high TIBC, strongly indicate iron deficiency anemia. Vitamin B12 deficiency typically presents with macrocytic anemia and neurological symptoms. Anemia of chronic disease usually presents with elevated ferritin levels. Thalassemia minor would show microcytic anemia but normal iron studies and does not typically present with low ferritin. Question 38. A 55-year-old male patient with a history of diabetes and hypertension presents with fatigue and pallor. His hemoglobin is 9.2 gram per deciliter, and his respiratory count is low. What is the most appropriate next step in diagnosing the cause of his anemia? A. Bone marrow biopsy. B. Iron studies to check for iron deficiency anemia. C. Vitamin B12 and folate levels. D. Renal function tests to evaluate for anemia of chronic disease. Answer: D. Renal function tests to evaluate for anemia of chronic disease. Rationale. The most appropriate next step in this patient with a history of diabetes and hypertension is to evaluate renal function, as chronic kidney disease, CKD, is a common cause of anemia in these patients. Renal function tests will help determine if anemia is due to CKD. Bone marrow biopsy is not indicated as the first step and vitamin B12/folate levels are more useful for macrocytic anemia. Iron studies are important for diagnosing iron deficiency anemia, but are not the most likely cause in this patient. Question 39. A patient with a history of rheumatoid arthritis presents with fatigue and pallor. Lab results show low hemoglobin, low respiratory count, and elevated ferritin. Which of the following is the most likely diagnosis? A. Iron deficiency anemia. B. Anemia of chronic disease, ACD. C. Vitamin B12 deficiency. D. Folate deficiency. Answer B. Anemia of chronic disease, ACD. Rationale. Anemia of chronic disease, ACD, is common in patients with rheumatoid arthritis and other chronic inflammatory diseases. The patient's lab findings, low hemoglobin, low respiratory count, and elevated ferritin, are characteristic of ACD. Iron deficiency anemia would show low ferritin, and vitamin B12 deficiency typically causes macrocytic anemia, not the microcytic anemia seen here. Folate deficiency is unlikely to present with elevated ferritin. Question 40. A 40-year-old male with sickle cell disease presents with severe pain and swelling in his joints. He is febrile and has a low hemoglobin level. What is the most appropriate initial intervention? A. Administer intravenous fluids and oxygen therapy. B. Start antibiotics for possible bacterial infection. C. Administer erythropoiesis-stimulating agents, ESAs. D. Begin blood transfusion therapy immediately. Answer. A. Administer intravenous fluids and oxygen therapy. Rationale. The primary treatment for a sickle cell crisis is intravenous fluids to rehydrate the patient and oxygen therapy to improve oxygen delivery to tissues. Antibiotics are not indicated unless there is evidence of infection, and erythropoiesis-stimulating agents, ESAs, are not typically used during a sickle cell crisis. Blood transfusions may be considered later if the anemia becomes severe, but the immediate focus is on managing the pain and improving oxygenation.
If you found this video helpful, don't forget to like, subscribe, and share with your fellow nursing students. Hit the bell icon so you never miss an update. See you in the next one. Happy studying.